Good evening, everyone, and welcome, and particularly welcome to all the new aspiring young doctors. Today we have a very interesting presentation. This is called an inaugural lecture. So when you become a professor, you come and tell everybody else what a great guy you are. Not quite. But Adam is here to tell us about his journey to getting a chair, sorry, it's called the not a chair, it's called just a professorship, isn't it? Yeah, there's a slight difference between the two, don't worry about that. Okay, so who is Adam? Adam is one of our consultant cardiologists here, and he joined the trust in 1999. He's an interventional cardiologist, and I can tell you he's one of the top, okay? Many of my colleagues have been to him. I haven't fortunately been there, but he's excellent, I can tell you that. Apart from that, after his training, he sort of was a junior and an intermediate British Heart Foundation fellow. And then with the help of which he actually traveled overseas as well. And he's worked as a Wellcome Institute with Professor Salvatore Moncada, who's a world expert on L-arginine. And Adam has worked on the L-arginine pathway. He'll tell you what that is. So don't get worried now, okay? Then he got appointed here, and then he wanted to, and he joined the two greats. They're probably online. Professor Douglas Chamberlain, you probably know the Chamberlain ward, and then Richard Vincent. And he worked with them, and he worked on multi-center trials, and he had his own trials to answer. Yes, and he told me recently he's taken a new job in the Royal College of Physicians. Unfortunately, that wasn't given to me, but I'm sure that's another great achievement. So I will welcome Adam to tell us this journey. Over to you, Adam.
Well, thanks very much. It's not often you get an opportunity to indulge yourself for an hour, reflecting on all the great opportunities I've had in my training and in this astonishing profession, which seems to be under the great spotlight at the moment of concern that this great profession is something which a lot of colleagues are not wanting to pursue. And I hope in the next hour I'll tell you what a great profession this is, and it has been and will continue to be for me. And the enthusiasm and optimism I have for medicine, I think will be seen, I hope, through some of the work that I've been involved with and some of the astonishing privilege I've had to work with some of the greatest minds that certainly I've had the privilege of being with. So the NO in the title is related to nitric oxide, something that I'm going to try and educate about. It's late on a Thursday evening, but it's an astonishing story, really, of how something so straightforward and simple was so recently discovered. This guy, Bob Furchgott, one of the most astonishing physiologists there's been in the 20th century, he only wrote a handful of papers, all of them led to his Nobel Prize. And this was the major paper that he discovered. There's always been a paradox that if you give acetylcholine in humans, it enlarges the artery. And yet, if you give it to them in a bath, on the bench, it vasoconstricts. And it's a paradox which nobody fully understood until Bob Furchgott realized that in preparing the rings for their bench experiments, they were injuring the inner surface of the artery. And if they did it very, very carefully, they discovered that the artery vasodilated, and a phenomenon which we knew about in acetylcholine, because it was just that simple observation of the experiment. And he said, in fact, you need an endothelium, the inner lining of the artery, for an artery to dilate. So I then, well, the Wellcome Institute at the time was run by a guy called Professor Salvatore Moncada. Now, he not only identified that nitric oxide was what they call endothelial divide relaxing factor, he also discovered prostacyclin when he worked with John Vane's group. So there have been discovered two major vasodilators which have had an impact on clinical medicine. It's an astonishing achievement for someone who was brought up as a poverty-stricken El Salvador individual. And if you ever have a time to see his story, it is amazing. Anyway, he discovered that endothelial-derived relaxing factor, for which he was known of for many years. It had been proposed by Bob Furchcott that it was nitric oxide, but Moncada's group proved it. And so EDRF, it turned out was nitric oxide. Now, this is a complicated slide, but in fact, if you look at the basis of it, you have an amino acid, L-arginine. There's a variety of enzymes, which I'm going to tell you about, to come to nitric oxide. This is the endothelium where all the action happens to convert it. And this is in the smooth muscle, which is the facilitator for vasodilatation. So if you take this away, clearly you don't get any nitric oxide. And so the idea at the time was that the systemic vascular resistance, it was called that, was resistance, it was constriction. And in fact, all the circulation is actually under constant vasodilatation. And I think it may seem very straightforward to think about that, but I mean, to change physiology on its head, which is essentially what this did, was a remarkable achievement. So nitric oxide continually released, and as you get a little bit older and your endothelium thickens or it becomes furred up, or then clearly it doesn't produce the nitric oxide and it vasoconstricts. And nitric oxide also, I'll tell you about in a moment, has an effect on platelets. And this is a remarkable man who was my MD supervisor, who was a very emotional, intelligent Polish physician who Moncada had attracted to his group, called Marek Radomski, and who is a lovely and very able man. And he took a clinician who was a cardiologist and helped me through some of the stuff I'm going to show you in a minute. And I'm very grateful to him, and he will forever remain an important part of my family. He showed that nitric oxide in platelets had an effect for preventing platelets sticking together and preventing platelets from sticking to vascular walls. And so not only was nitric oxide had a vasodilator property, but it also had antiplatelet effects. Now, clearly, platelet thrombus is very important in vascular disease. So these were important underlying mechanisms that were being established here. So at rest, there's no nitric oxide. When you're activated, you get nitric oxide synthase, and platelets produce nitric oxide as a factor in regulating adhesion and aggregation. Now, I'm boring you with this because it is relevant for when some of the experiments and papers we got involved with. This is the horseshoe crab, Limbulus. And the reason it's of interest is because it has never changed in hundreds of millions of years. So if you look up in Dorset or wherever it is, you find all these things, it's exactly the same. And so my colleagues at that time, with another remarkable man, John Martin, who was professor of medicine at King's at that time, was also my co-supervisor for my thesis, took blood from this horseshoe crab and discovered it only has a single cell. The hemocyte it's called. So the hemocyte is a white cell, it's a red cell, it's a platelet. It all has functions of it. And obviously, as we have all evolved, these cellular functions, but it's of interest because the Limbulus crab is, has that basic, and they found to have L-arginine nitric oxide pathways in these hemocytes, showing that it is one of the most primitive evolutionary pathways that we started with, which makes sense because of its easy understanding of pharmacology. Now, just to complicate things, there's another nitric oxide, and this will become clear if you look at the pathology, which I'll show you. Inducible nitric oxide synthase in health is not apparent, but when you get an immune stimulation of this particular enzyme, what they call the immune nitric oxide synthase, it starts to produce huge amounts of nitric oxide. And so once it's expressed, you'll get lots of nitric oxide. And this could be at a local level, at a cellular level, or a more systemic level. So for example, in septic shock, when you've got widespread cytokine activation and you get very low systemic vascular resistance, the outpouring of nitric oxide is one of the most important fundamental reasons why that happens. The big problem is with the different enzyme inhibitors. Nitric oxide is very important for life, vasodilatation and platelet aggregation, platelet adhesion. But if you then inhibit it, then you'll turn off the good nitric oxide as well as inhibiting the bad. And I'll show you some experiments about that. So if you look at the nitric oxide synthase inhibitors on the hypertension, and you'll see here that, let's go back one. You'll see here that Patrick Vallance, the chief scientific officer, was this was his main claim to fame from pharmacological and scientists. And in fact, Patrick was the physician prior to me at the Wellcome Institute that had been working with Salvador Moncada. And they gave this LNMMA, it's called, an L name, which are inhibitors of nitric oxide, and found that if you gave this to patients in septic shock, the vasodilatation they get is inhibited and you get vasoconstriction. And the reason we don't use this on a systemic basis is they haven't been able to separate out the different enzymes inhibition. And so sometimes this can actually deteriorate small vessel function with the vasoconstriction that you get. And that's how Patrick used to look. I'll show a picture of him. That was so when I did some research with Patrick, which I'll come on to in a moment. So my interest was the idea that if you have a big swollen heart, say myocarditis or dilated cardiomyopathy, no one understands why these conditions have a heart that doesn't work. No one understands the mechanism. If you look at it under a microscope, so myocarditis, you've got a lot of inflammatory cells. Dilated cardiomyopathy, an unusual condition, which actually under a microscope looks pretty normal, has a normal blood supply to a heart, but there is some factor which is inhibiting its function. And that's still not fully understood what that pathology is of that not uncommon condition. 50% of heart transplants in this country will have that condition, which lead to it. So we were interested in understanding the hypothesis that in fact excess nitric oxide may be a factor in the impairment of cardiac function and might lead to some pharmacological options of improving function. Now, Moncada's group had already started the ball rolling, looking at myocardial preparations in the lab and giving them cytokines and activating them and showing that if you do that, you get a massive nitric oxide spike induced by this enzyme. So there was no doubt that if you inflame a heart, it produces excessive nitric oxide. Nitric oxide vasodilates. Could this be the mechanism whereby cardiac function is impaired in these unusual and rare conditions? So one of the first projects I was involved with was measuring the enzymes in different human cardiac pathology. And we looked at 7 cases of patients with dilated cardiomyopathy and 7 patients who had heart muscle taken from them who had valvular heart disease or ischemic heart disease, or the etiology of their knackered heart was not an immune modulated enzyme pathway. And that has had a lot of interest over the years. And this was taken from my thesis. I couldn't find the original paper. So, but this shows that here, the iNOS is expressed, the inducible nitric oxide, which produces lots of nitric oxide, and the dilated cardiomyopathy, and the constitutive nitric oxide, the non, is mainly the main enzyme in other pathologies. And we went on to look at much more pathologies, postpartum cardiomyopathy, myocarditis, by combining groups. And one of the things I learned in this period of research was the strength of combining with other groups of individuals who have similar interests. I was able to go and get this from frozen heart muscle tissue, from groups at George's, from groups at King's, and there's no doubt collaborative research is so much more powerful than coming on your own. And when we set up the research program down in Brighton, this was part of the philosophy of what I wanted to bring. And I could measure these nitric oxide synthase, and so I had all my mates who had various interests. So for example, I was sent some bowel from patients with ulcerative colitis from my mate Andy Godkin, who's a professor of gastroenterology in Cardiff. And we found that the inducible nitric oxide synthase is, and I'm telling you now that any inflammatory condition will express this enzyme. This is an important mediator of a lot of local and systemic pathogens. So these patients who had active colitis, I only throw that in because it just showed that we were stumbling across a pathway which had yet to be described, but in fact was apparent in loads of pathology. I want to talk about this substance here, S-nitroso-glutathione. If you look about the other end and say, well, as I said to you, that there's pathology where you get a lack of nitric oxide, so you may have vasoconstriction, you may have loss of endothelial activity because of atheroma. And so this substance, S-nitroso-glutathione, which is called SNOG, is a systemic donor of nitric oxide. So it might be useful in conditions where there is an absence. And I've done some work with, again, with Marek and Moncada and Patrick Valence. And Patrick was a great fan of the forearm plethysmography. And we took some platelet samples, and we showed here that there was, that you could, as you gave the infusion, at low dose, you had very little vasodilatation, but you had lots of inhibition of aggregation. So that was the potentially that we could give this agent as an inhibitor of platelets in conditions that pathology was induced by platelet activation. And this led to another series of experiments we did. Look at poor old Patrick, he really has aged. He's such a handsome chap, and he's just been wrecked by being chief political. Terrible, isn't it? He is the smartest, loveliest bloke you would want to meet, actually. I mean, I don't know whatever you get from watching him on television, but he's a really lovely man. Okay, so obviously coronary angioplasty, sticking a balloon in a coronary vessel and blowing it up, potentially is the most platelet activating event you could want to do. But interestingly, at the time we did this, it had never been proven that that process had actually happened. So we took some venous samples from coronary sampling and using some techniques where you look at platelet activation. And we looked at here at P-selectin and 2B3A, these are both receptors expressed by platelets. And we found that, in fact, they were expressed during angioplasty, and if you give GSNO, you can inhibit that expression. And so that was potentially quite exciting at the time. That got into the Lancet. It was the first time that platelets had been shown in vivo in humans having an angioplasty, and that there was a mechanism for inhibiting it. Now, this is quite a long time ago now, but it did show that we now have systemic platelet inhibitors which work on very much more different pathways, aiming for these receptors more selectively. But it showed an interesting fact that you could separate the vasodilatation and antiplatelet effects of this particular agent. And then there was a big preeclampsia unit at King's, and we were able to have a look at some of the systemic effects of preeclampsia, where you do, I'll show you here, you get platelet activation, hypertension, and if you give S-nitroso-glutathione in women who are severely preeclamptic, you can inhibit this, you can reduce this, and you can increase the uterine and fetal Doppler flow. So, of course, it's one of the most significant causes of baby loss in some cultural departments in the country. And so this was a unit, Stuart Campbell's group at King's, who we collaborated with, looking at this group. So that was my life in research before I came here. And then I was a rather green clinician, having all this under my belt. And Chris Davison and his colleagues interviewed me and chose me to come and join the team here. And we were part of, my job here was to help set up the Tertiary Cardiac Centre. At the time, for those of you who don't know, cardiac surgery had to go to London. And so part of my job in the appointment was to bring all adult intervention, adult cardiac surgery with my colleagues, and make sure that there are very few things that you couldn't be looked after in the Sussex Cardiac Centre, we called it, in Brighton. And so that was quite a big job, setting up a new cardiac centre. There was quite a lot of nasty politics from London who didn't want us to succeed. You know, that was the first time I saw that side of medicine, which isn't terribly attractive. In time, I had to set up a primary angioplasty service. So I'll talk a little bit about primary angioplasty. So when you have a heart attack, nowadays, you have an immediate procedure to open a blocked artery. But if you look at the evolution of that, that's already been quite recent. So prior to defibrillators, death from myocardial infarction in this country, 30% at 28 days. Defibrillators reduced it to 15%, aspirin reduced it to 10%, thrombolysis reduced it to about 7%, and primary angioplasty now is about 2%. So it's an astonishing improvement in outcome from patients. And we used to have our coronary care unit littered with people suffering the complications of blocked arteries which had been untreated. And now, of course, we don't see it anymore because it's all dealt with promptly with a very efficient service. And that has, I think, has been, the credit that the coordination and the implementation of that has been fantastic. And of course, stroke are going through the same revolution at the moment, perhaps at a slightly slower rate. We had to develop a cardiac imaging service, and to do that, we appointed the remarkable Rachel James, who I'm sure most of you know here, who is a national figure in cardiac imaging, and has also set up our adult congenital heart service unit, and is an expert on obstetric cardiology, and has also helped out in the pediatric cardiology world. And so she's been a fantastic asset and continues to be for us a fantastic appointment. And following on, we appointed Vicky Parish, who has sorted out our cardiac imaging and now cardiac MRI and cardiac CT scanning, and she's developed our pulmonary hypertension service, which is also something. So all these patients which used to go off to London, gradually the Sussex Cardiac Centre here in Brighton has been able to provide all these services. The other thing that's had an amazing improvement in the last 10 years has been heart failure. So heart failure outcomes were really desperate not that long ago, and they are being transformed where cardiac function can be improved with pacemaker facilitation. They can be the 3, 4, 5 drugs now making serious impacts on mortality. So the diagnosis, which used to be, a little bit by myeloma, it was just a matter of time, is now people can have good quality of life as long as you get the right treatment and seen by the right people. And that's moved really quickly. And so the prospect of treatment for that has also moved on. I'm going to talk a little bit more about our electrophysiology service, which has been shouldered by Sean O'Noonan. And we've now got 4 electrophysiology appointments, and I'll tell you why in a minute. And the other thing that's really happened in the last decade is a percutaneous valve development, which has been led by the heroic Professor David Hildick-Smith, who has really put Brighton on the map internationally as one of the leading percutaneous valve units in the world. So his appointment here has really meant that in a very short period of time, the Sussex Cardiac Centre is represented on an international stage, and the developments continue. And if you haven't been able to see any of David's talks about the various things they can do now percutaneously on valvular heart disease, it's certainly worth getting a ticket if you can. So Sue Ellery has been part of the team that's developed the heart failure service, and more recently appointed Steve Coombs, and the things that they can do to hearts, particularly with what they call biventricular pacing, and make these hearts which aren't working start working again, has been a massive game changer. And apart from all that, I had to help set up the research centre. Now, of course, we had a bit of an advantage. Okay, let me just talk about our clinical outcomes. These, we continually supply data to the national database. And just to reassure you that if you do get looked after here, you get looked after pretty well, I hope. This is for percutaneous coronary procedures, where this is the average for the country, and we're the blue line. Which is this is the MACE, this is major adverse cardiac events, and this is the number of cases. And as you can see, you do pretty well here, so that's pleasing. David's percutaneous aortic valve, so we do high numbers with, and this is again mortality, and you can see that we're one of the lower mortality units in the country, and that continues to grow. So these percutaneous valves, Dave and his team will now be 8 a week, with now aortic valves going in through a hole in the leg and the patient's going home the next day having instead of a 7 to 10 day open stenotomy. So these are big changes. So these two great men have already been mentioned. Douglas has just asked somebody a question that he knows they don't know the answer to, which his ward rounds were legendary. But again, he involved BRIGHTON in some of the initial trials that were set up. The ISIS one, I don't know if you remember, some really landmark trials. BRIGHTON were deeply involved in that, mainly due to Douglas's involvement with the Oxford group. And again, the remarkable Richard Vincent, who was also a professor of cardiovascular medicine and set up the postgraduate MSc cardiology course, which has a reputation which goes beyond these shores. So they had an infrastructure here when I started, and that's part of when you want to develop a research program. If you don't have that, it's almost impossible to move forward. So what we started doing is now we started having the work here. It was safely done. We were making appointments and developing teams. And you can't suddenly do New England Journal research on your own. What you have to do is phone up your mates and make sure all the big trials, all the important questions, that BRIGHTON became part of that national conversation. And that's what we did. So here's a trial run for one of my colleagues from St. Thomas's. And so I made it clear that I wanted to be involved. I wanted to be on steering committees, and I wanted BRIGHTON patients to be involved. And I said, if you do get our patients involved, our infrastructure, our team we have down here will make sure it happens effectively. And so this was a major trial looking at diabetes, comparing coronary artery bypass surgery to intervention that was run out of the Hammersmith Hospital, and BRIGHTON patients gave a major contribution to that. In the old days, when you got thrombolysis for your myocardial infarct, if it didn't work, you were then randomized in this trial to having a rescue angioplasty, or you were left alone to get on with it. And this trial showed that if after failed thrombolysis, you had conservative therapy, you did much less well than if you had the rescue PCI. And this was part of the hypothesis emerging at the time, to actually get the artery open as soon as you can, as quickly as you can, forget the drugs. And of course, we had to undo all the infrastructure that Douglas and Chris and his colleagues had done to make sure prompt thrombolysis happened. And that was difficult, particularly for the ambulance crews, who I think had felt had great ownership and were incredibly diligent in delivering a service they then had to be asked to withdraw. And it seemed crazy to them to give a drug in the field. And then I had to say to them, look, actually, even waiting for an hour and getting the artery open is better than the drug, because the drug only works in 50 to 70% of cases. Angioplasty works in 99%. And so, anyway, so that was in the New England Journal. So that was nice for BRIGHTON to be represented. I talked a little bit about myocardial infarction. This is Paul Wood, who wrote this book in 1948. And I only put this up just to tell you how quickly it's gone. He was an itinerant smoker, died of proximal LAD disease, which at the time couldn't be treated. It was pre-surgery. And he said you had to go to bed for 2-3 months after acute coronary. And they had funny ideas about starving them and stewed fruit with sugar. You know, this is in major textbooks of cardiology, which were, people paid lots of money for. And if you look at this was his obituary that a friend wrote. And you can see in terms of education at the time, this was part of what I grew up with, this very humiliating, aggressive, patronizing, if you didn't have the knowledge, then, diminishing attitude to teaching. And if you look at how teaching has changed in a pretty short period of time, some people would say they want it back.
Don't be ridiculous.
And as I said, at the moment, so we've just done a case actually before we came. The ECG is done in the field, in the cardiac unit. We know it's there. They activated, the patient came straight to the lab. Within 10 minutes of arriving, the artery was open. And, it's a revolution. and the many players who have allowed this to happen. You know, I find it dispiriting when you read in the paper about how depressed everybody is with the NHS and all these sorts of things. It is astonishing what the NHS has achieved in some of these fields. If I just tell you all of those areas, and I'm going to tell you some more in a minute, that we've been involved with, you know, the era of expectation that has arrived in medicine, we're going to be a bit behind, but it's because there is a reason for it. And some of the ideas and developments and technology that is coming out is amazing. I think it's not that far that a smartwatch will detect that your troponin rise before anybody else does. That you'll have an emergency infarct-related angioplasty, but you'll have a bioabsorbable scaffold. So that's a stent, but it will dissolve after you've needed it, and it will restore your endothelial function. You'll get infusion of BM-derived stem cells, and that will help recover your myocardial infarction that you've lost. The defibrillators, which used to be massive boxes in here, will be the size of your thumbnail and will take four seconds to put in after a bit of local anesthetic. And you'll have some gene profiling of your children. Now, whether or not we want that, and you know, we'll all live to 150, it'll be a nightmare. But these things are moving very, very rapidly. And this sort of scenario isn't that far away. Whether or not we want it is a different question, what it will bring. We're now going to move on into, we've now established ourselves. We're now involved in lots of multi-center trials, both in the UK, but internationally as well. And now what I wanted to do was to make sure some of our own ideas started to develop from within, and BRIGHTON led the way in some of these trials. And this is the remarkable David Hildick-Smith appointment we made 2 or 3 years after me. He has, this was the first trial out of BRIGHTON. So we coordinated the British trial, and I'll show you the team that helped do that. This is a highly cited paper. It's down on the management of bifurcation disease in coronary intervention, which I'm sure is a matter of great interest to you all. But in fact, it's a very hot topic and continues to be about the best way of managing coronary disease at bifurcation. And it isn't, you don't need, it's not just the enthusiasm and drive of the clinicians. This is the research team that we have built up and built on Chris and Richard and Douglas's efforts. And, you know, if you add up the income we need to make sure that they all go home and have food on their plate, it's a lot of trials. And there'll be 30 or 40 cardiovascular projects now going on at various stages in BRIGHTON. And so that's all happened in a pretty short space of time. And I think it's something I think we all feel very proud of. I have no, I would not even pretend to think that my contribution is relatively modest. The main driver for this has been David Hildick-Smith. And these are some of the papers and trials that David's been involved with the BRIGHTON team that we've been able to contribute. Cryptogenic stroke, transcatheter aortic valve, and now David's moved on to the mitral valve, and that will that's producing another rich area of research. Coronary angioplasty and left main stent disease, you'll see David. And so what's happened rather rapidly is that we not only now involved in some of these studies, but these are our projects. We're running them, and we're running multinational studies, and my team and David's team are able to facilitate that. And running trials is a big deal. I'm going to tell you, this is a trial I ran. It's a multi-center trial of octogenarians. It's the first trial that would ever had all the patients were over 80 that's ever been published. And the reason you don't have old people in trials is because things happen to them because they're 80. And of course, that's quite difficult. And in fact, it affected a little bit of this outcome. But the reason we did this trial is, and this is a presentation we gave to the major American Cardiovascular Society in the late breaking trial session. And this was really the hypothesis. We have elderly patients who say are 88, they've had a stroke, they've got renal failure, they've got diabetes, they've got multiple comorbidity, but they come in with refractory angina. And the question is, what's the best management? They've got complex coronary anatomy. And we had, at that time, we had two sorts of stents. We had stents which were bare metal. And the advantage of that is that you only took blood thinners for a month. The big revolution in our game has been drug-eluting stents. And the disadvantage is you have to take blood thinners for a year. So in this cohort of patients who were very elderly, prone to falls, perhaps prone to not taking their medication, polypharmacy, complex other health morbidities, should we go for the bare metal stent with the short bleeding option, or the drug-eluting stent would be better for their coronary anatomy, but it meant there was a consequence to that with the bleeding regime. And of course, the complexity of the coronary disease was very challenging. It was quite a challenging trial. And those are the issues I've just talked about. So this is the hypothesis that drug-eluting stents would prove superior to the bare metal in terms of combined endpoint of mortality and stroke. I just put a slide up to tell you how much it takes to organize your own trial. I'd linked up with a good friend of mine, Jose Maria de la Torre Hernandez, who is a cardiologist in Santander that I'd met in some meetings in Spain and in Europe. And I have, one of the great tragedies of Brexit actually is some of these collaborations have soured somewhat. And whether or not that relationship will be re-established, I don't know, because some of the funding patterns have changed. And you have a steering committee, a drug monitoring board, data safety, coordinating centers, management. We used our own, we set up our own database, which was run through some tech guys and companies that we have. I don't know if any of you know Derek Robinson, who's a mathematician down at the university. He's been incredibly helpful in understanding things I can't even begin to understand. But and he's been a great analyzer of the data we've produced. We've got clinical events committees, and we had to raise money for this from industry. Getting money from organizations where you don't have a reputation as being an academic is actually very difficult. And because essentially, not surprisingly, and I would do the same if I were, say, a BHF professor, I would make sure my unit got the money rather than some, some of these chaps in Brighton. Anyway, so we've been able to fund it through joining in other trials and get it that way. But it took a lot of energy, and this took up a lot of my time dealing with the trial. Anyway, lots of centers were involved. You have to make sure you're the lead center when you run your own trial. So I had to crush everybody else and make sure everybody went in, and that's the other thing. The other thing is that there's lots of famous people in the trial centers I joined, and I found out the difference between doers and talkers. And there's some very famous people who found it almost very difficult to employ anybody in these trials, but were very keen to be involved at the latter stages when the paper was being written. And anyway, so they're widely used in America, in Spain, and also in the UK. And if you look at the age of these patients, 83, and there were some minor differences down here, previous cabbage, and I think there was something else, the previous MI. So there were some slight differences in this very old bunch of patients, but 800, quite a big trial. And then some of them came in with unstable angina and some had stable angina, and that was criticized by some of the reviewers. But you'll find that there was no difference in death, no difference in major hemorrhage, which was the surprise because that was part of the hypothesis. But your MI was much less if you had the new stents, and your chance of coming back with further angina was also much reduced with the new stents, and the strokes were about the same. So the new stent, despite the prolonged bleeding, and at the time it had quite a thing. So we got that into JACC. So the great Kaplan-Meier curves of Derek Robinson. All my papers have Derek Robinson Kaplan-Meier curves that look like this. So Derek's very interesting actually, because he has no interest in the thing. You have to put all of it into mathematical boxes, and he does the maths of the problem in front of him. and produces. And he wants to know what the question is from row 43, you know, in terms of analysing it. It gives great independence, if you like, because he has no interest in the result. And you have that moment when you've run trials when Derek produces the goods, and it's a great frisson of excitement when it happens, and he has no idea what you're excited about. So it was a big study for us, big study, put Brighton on the map. Big study I've done now. There's a big study in geriatric cardiology. I do lots of research, and there's lots of studies using this data with other multi-center trials and other colleagues, mainly around Europe and Italian, where this has now been published in the Lancet and in the major cardiovascular journals. The other trial that we got involved in was a similar hypothesis, but in the elderly, with patients who come in with unstable angina, and whether or not, because you're at 93, normally you'd go off to the lab, find out what was wrong with your artery and put a stent in, have a bypass, or whether or not at 93, the demands of actually putting these tubes in and doing things to people is something that's sensible. It commits you to lots of drug therapy, and it may be there are multiple problems with you. So this trial was to say if you came in at 88 and you had unstable angina or a myocardial, not a proper myocardial infarct, what we call a non-ST elevation myocardial infarct, it was whether or not we should just put you on tablets or whether we should do something. And again, this was a UK national trial, and again we presented this at a late-breaking trial. And some of my colleagues here from throughout the country have been very helpful in developing a group of us who are interested in providing these sorts of trials. And of course, when I started, octogenarians in the cath lab, 3%, 3%, 20% now. So it's just a reflection of modern life. And again, an astonishing improvement that we've had in healthcare that means that, in fact, everything, we get cardiovascular disease, but it's all shifted to the right. It presents later. It presents, so people may be 90 having their first heart attack. And so these were trials that were trying to establish, is age a factor? All right, does it matter how old you are? Or does the wind start to cause it? And the results of this were very interesting. Because the very elderly are always excluded from all trials. And so there's very little data on this. All investigator, multi-center, open label trial. And one of the problems we had in recruiting to this trial is people did not want to leave people on tablets. They wanted to go and do things to people. And yet you have this sometimes where you get a geriatrician coming along and saying, what on earth are you doing? Leave him alone. You know, he's 93, he's in his chair watching telly. You know, here you are shoving stents in. You know, you must be mad. And in fact, if you look at the combined endpoint between medical therapy and intervention, there was no difference. And this challenges the current guidelines. These trials of challenging, saying, well, yes, there is benefit from doing things to people who have had that, you know, but this was a small trial. It took us a long time to recruit. There are some faults with it. It's not definitive. It's relatively small numbers, but it's part of the mix of some increasing data trying to ask this particular question. And I'm proud of the fact that Brighton have been able to contribute to that particular element. So just for the last 15 minutes, I'll just tell you a little bit more. John Silberbaum, Jack McCready, two colleagues who you will hear more about as I run off into the sunset of the autumn of my career, or perhaps winter, I don't know. These are electrophysiologists. So when you have atrial arrhythmias and you have ventricular tachycardias and things are troubling you, you go and see these people who put little catheters, understand your circuitry, and take out the problems with something called catheter ablation. And when you have ventricular tachycardia, it's very problematic. Atrial tachycardias, I think, it's fair to say there is very little they can't do now. Ventricular tachycardia is a different problem in the sense that to ablate it, usually all you do is set up other circuits. So you can end up getting rid of that particular problem. And what John pioneered, again with Dave Hilditch-Smith, was a technique where you get, instead of going inside the heart, you go outside. And you can do the electrophysiological ablation from either side of the heart. You may think, well, how on earth do you do that? Well, they punch a hole through a vein in the coronary sinus into the pericardium. And then there's a layer, and I think surgeons will probably understand this. You can peel it away. They put carbon dioxide into that space, and then they can put their catheters in to do the ablation. So this is what they call epicardial ablation, as opposed to endocardial ablation. So VT, it used to be amiodarone deficient condition. You know, you used to have a terrible drug called amiodarone, which stopped your VT, but poisoned you with all sorts of other conditions. And you could always spot them in the outpatient clinic. But now these clever individuals are able to access, so here's the popping out into the pericardium. This is the wire going in, and this is the CO2 separating the heart from the pericardium so you can get your catheters out. When you're finished, you take it all out and it all closes off again. And so their results for ablation of VT have been transformed. This was paper of the year in Journal of Electrophysiology and in their sort of arrhythmic world as a pioneering part of, and again, there's very good appointment for Brighton. John in particular is an incredibly clever man, and it's not only doing these things and being involved with trials, but actually come up with ideas and make them happen safely and move things forward is what I've been particularly proud about their appointment. They also happen to be very nice guys as well. So we've made a new appointment. This is Justo Calvo, who's a Spanish cardiologist. And again, he is a whiz in the cath lab, and this epicardial access for ablation of ventricular arrhythmias, people are knocking down their door in their lab where they're learning how to do it with the help of these expertise. So hopefully when I retire and David retires, I want to make sure the cardiac department is in good hands moving forward. And I just thought I'd share that with you to encourage. There will be ongoing progress. And finally, something I've always been interested in is a little bit of what I've been up to more recently is, if you look at the GMC, it's incumbent on all doctors to evaluate their performance, determine where they stand compared with their peers, a constant drive to improve their patient care. And of course, that's part of appraisal. You would have thought it's part of being a normal doctor. You would imagine if you went along to somebody, they knew what they did, how good they were, what their results were on the national database. But of course, this is all fairly new. And if I went along and my wife had cancer and I wanted to ask that unit, how do I know that I should be here rather than the Marsden? These basic questions are only just beginning to emerge and beginning to be understood. And that's because our data mechanisms are getting better, our analytic mechanisms are better. And I've always been interested in cardiovascular disease, obviously. And if I show you a couple of things we did. So we developed a Bayesian index when I was a senior registrar at King's. So what this was you took a cohort of patients, you said, if we analyze the risks involved with this patient and what the outcome was, and then you create a score from that, and then you use it to see if your predictions were right in the next cohort of patients. And that's what ROC curves are all about in terms of your predictability. So you can say, instead of saying, oh, well, you have an angioplasty to your left main artery, well, that's a 5% risk. You can actually say, well, actually, you've got poor left ventricular function, you're 83, you're diabetic, your kidneys don't work properly. And that person, in fact, looking at the data, is 13%. So it gives you a much more tailored, more specific risk. And we can be much more honest with patients and include them in the consent process. When I set up here, I inherited a region which had variable, in my opinion, standard of angioplasty practice. And in order to understand that more, we set up a program where you were randomly selected to have your case evaluated by some peers. And it was a very successful project. And Chris will remember the energy it took to involve, because it involved, this was pre-video technology, we had to arrange meetings, but I was concerned that inappropriate practice was happening without proper MDT discussions and things that we all expect now. But this was all part of trying to understand that if you had an angiogram here and your outcome actually might be very different to having it over there, that clearly isn't right. So this in fact is my the cricket team of all the specialists that were involved in the process. And in fact, interestingly, they've all been very keen in developing it because it provides you with your own thermometer about your care. And I think if I had proposed that this was a model of care for all of us, that you should every now and then get somebody who does what you do and looks at your work, you know, whether it be outpatients, clinics, review your letters, and just have some opinion about from somebody you respect. It has to be a good thing. Now people say, oh, I haven't got time, or I don't like, or you know, or there are always reasons why it shouldn't happen. But reflecting and learning from others is a key part of being a good doctor. And so I got involved in the British Cardiovascular Society. I was chairman of the Quality and Standards of what they call Interventional Society, and subsequently the British Cardiac Society. And then I joined the Royal College of Physicians invited review team. And I met this remarkable man, Peter Belfield, who set it up. He's a retired medical director from Leeds, and this is the president of the Royal College of Physicians, Andrew Goddard. And this is Peter getting his gold medal from Andrew for the amazing work he's done in setting up the invited review service. So I was Peter's deputy for a few years, and Peter's now retired, and I'm now the medical director of that service, which is why I do a little less cardiology. But this is what we do. So I've got a team at the Royal College of non-clinicians, and our job is to, these are professional writers. These are people who have had experience of journalism and lobbying and are medical experts, and they write well and they write decent reports, but they understand analysis, and they're an astonishing team actually. And we are invited to go into any specialty. It's not cardiology, any specialty. So last week I was at a melanoma review service where there'd been some dispute about the diagnosis and treatment, and they couldn't sort it out locally, so they wanted an external view on it. And we've done some hematology, and we've done all sorts of interesting specialties. It's been fantastic for me to go into a little spotlight into, usually there's a spat or a problem or it needs to be resolved, but there's also an opportunity to meet some great people from other specialties who are there to try and help whatever problem it is we've had. And there are some, unfortunately, doctors who are not good. For whatever reason, they do things to people that they shouldn't. And of course, we need to have mechanisms to try and make sure their patients don't suffer. So we look at patient safety concerns. We're going to see some stroke units shortly that have got poor outcomes from stroke units. And if you look at stroke, it's again a rapidly developing service trying to be provided by a service that can't keep up with what's demanded. And so some of the mortality figures coming through reflect that, and how they change it may influence policy at a national level. So we find individual behaviors and team working. Sadly, that's common, not as common as surgeons, but surgeons, of course, very strong-minded individuals. And provision of medicine in smaller units where they can't, for various reasons, provide quality in terms of volume, but of course their geographical isolation means that they've got to do the best they can, and sometimes having some externality will help with that sort of thing. So there's a lot of people I've made reference to here, both in my academic. The most important thing I'm grateful to, of course, is my wife, who listens to all of this and has to hear it, and has been a fantastic companion and sounding board. And just as an aside, she's in primary care and is coming home at 10 o'clock most evenings, and that's how primary care are going to move forward in the modern NHS. I think is currently the current model is unsustainable, but that's an aside. But I'm grateful to BRIGHTON, to my colleagues here, to the appointments I've made, and hopefully I've stimulated and interested you in some of the things happening in my astonishing specialty. And thank you very much for allowing me to indulge.
I was just going to make a comment in that having been the director of education here till recently, I just wanted to say that apart from the research. Adam and team have been amazing trainers, and we have had such brilliant feedback from undergraduates, postgraduates, and so on. So it is quite interesting that when you're really passionate about something, you can do it all. And I think you need to be congratulated. And I don't want to embarrass a couple of other people in the audience who are also equally brilliant at everything they've done. And Brighton is so lucky to have that sort of setup. And I think, we really need to appreciate that. And I would like to formally thank you for all that you've done.
Charlie, thanks so much. The one thing I would say about teaching is that I remember everybody who taught me badly. All right. I remember how rude they were, how uninterested they were. I can tell you them now. And you don't remember that when you're teaching. And it is our job to make sure our next generation are taught properly.
And the advantage of doing that well is that you attract the best guys back to your department. One way of building a good department is exactly that. Look after your trainees. Yeah. In fact, nearly all of the appointments we've made have spent some time with us. Yeah, so it's true. It's good.
Any other questions? Okay, if not, now we got some important task here. I'm going to hand over the microphone to Professor Reed, who's the Dean of our medical school. He's going to present Adam with the certificate and then propose the word science.
Adam, thank you so much. I mean, that was it. I love all inaugural lectures. I think any of you who've been to any of the previous ones which we've done will hopefully share that with me. I mean, that was a great talk and a great journey, actually, and a great example of transforming care through research and your own research and how that can have an impact in the longer term, and particularly through collaboration. I remember the EDRF nitric oxide paper coming out because I was doing some vaguely related work in the States at the time, fiddling about with tiny arteries in mice cremasters as part of investigative treatments for cancer, which seems very, very strange looking back now, but it was interesting at the time. But just little highlights, things like 7 patients can get you a paper in the Lancet if it's
the right question.
Genuinely a breakthrough. That's pretty unusual. And then a stream of great publications after that. Absolutely outstanding. And then, Brighton was lucky to recruit you, I would say, with that track record already under your belt. And fantastic that you came here. And that has been absolutely outstanding. And we now have 2 honorary BSMS chairs in the department, which is outstanding. It sounds like there's more to come. I would observe that cardiology is the new frontline in surgery. I think the blurring between surgery and non-surgery disciplines is just about dead in the water, really. And there's this complete overlap between what we used to call surgery and what we used to call medicine, and with radiology as well, all coming together. I think we need to be rethinking how we train people in those disciplines. And it's strange that we don't train people across all the disciplines in a much broader way. And that's partly, I would say, the challenge is to Royal Colleges to be more flexible, would probably be how I put it, because it's interesting to see how your Royal College of Physicians work mirrors what happens in the Royal College of Surgeons, and why are we still keeping those very, very old-fashioned looking divides. Anyway, I won't go off on that particular rant, but it's a very interesting way to start to work. We do a
lot of visits with them, actually.
Yeah, absolutely. It's entirely necessary, I'm sure. And I've just written down as the final thing, is sort of modest to a fault, and that's a good thing, I think, and it allows you to build teams and allows you to let other people flourish. Because one said to me, there's no limit to the good you can achieve by letting other people take the credit. And I think you've done that, but you've shared the credit, and I think you've done an absolutely fantastic job. So this recognition through an honorary chair, which is what it is, it's exactly the same as any other chair as far as I'm concerned, is very richly deserved. Thank you and congratulations.
Thank you.